We know this fact very well that the data, technology and research play an important role for nutrition outcomes, and there is a growing opportunity to change the landscape of public health nutrition with the help of the new ideas, the new evidences which we are generating from the field.
Dimagi is a tech for good company, and we have a product called ComCare. It's basically a platform, a no-code platform, and its focus it is an open source platform which is rated about 52 in GitHub in terms of number of downloads. It's got all inbuilt features, and it's a offline first platform with case management where you don't require programming abilities to use the platform. So this is the platform that we have used as a foundational product, and we have worked extensively in India in the nutrition domain, and we do have a set of components that we have developed for the nutrition sector in terms so that we can have a contextual based solution that can be deployed very readily for a nutrition context. So the platform that we have that's built on ComCare has got a lot of features. It's feature rich, right from registering the beneficiaries, and also looking at case management, SAM management. The pilot that we are working on currently essentially tries to build in a predictive model nutrition. So essentially what Dr. Srinivas already spoke to you about, the integrated approach that we have. So the machine learning piece that we have on top of that project, or which we propose to put into that project, would predict, taking some of the parameters that you see in the blue that is below, in the blue line that is below, in terms of other factors. It can predict a model by which it can say whether the child is tending to become malnutrition. So that's the predictive model that we have built in. And the reason why I spoke to you about ComCare is because it provides that sort of a foundational system, and especially case management features, which are very relevant in the context when you are looking at a larger problem solving, but drilling down to an individual to tackle cases and do exception management and target the individual. I think this is a very, very important takeaway. So you need to have large amounts of data, accurate data, and data that is time stamped. Plus, you need to have a whole set of other data for the engine to act and provide you the type of results. So that's the first key takeaway that I would like to underline. You have to feed data into the engine, and it takes the data, and based on the knowledge that it accumulates, it's able to predict the accuracy. So the accuracy of prediction of AI depends on what you provide. Can AI solve our problem? It'll help solve our problem, but the problem will have to be solved by you.
So I'm going to talk about ARMMAN's approach using tech plus touch.
So ARMMAN uses technology to create scalable solutions to impact access to health information and access to health knowledge of health workers at every level health system. And our whole idea, I hope, is that if women demand care and health workers are able to kind of give the kind of care early enough, there will be a 50% reduction in the number of delayed, complicated and irrational referrals to tertiary hospitals, resulting in overall reduction in maternal child mortality and morbidity. So our theory of change is we use technology, but we call it tech plus touch. Tech alone is not enough. You have to have requisite touch points, but if technology does the heavy work of going across to women and health workers weekly, you can keep the touch points to feedback, enrollment, two-way communication. So it's scalable. We do not create our own parallel infrastructure. We work with the government health systems.
So lastly, what we want to do is this. Imagine all the three programs go through the country. In the next 3 to 5 years, Skillkari and Mobile Academy will be through the country. So the databases in the backend will talk to each other. So what will happen is that if a part of the state does very poorly in pregnancy-induced hypertension, for example, we can use Skillkari to train the women more, Mobile Academy to train the ASHAs more, and integrated high-risk pregnancy management program to train the nurses, medical officers, specialists more. And when you come to health worker training, is this technology session. So we actually recently won the Gates Grand Challenger grant to use large language models, generative AI, in the training of health workers. So we develop these protocols on high-risk pregnancy management. We're actually doing machine learning with ARTPAC so that the machine learning tool that we develop, model we develop, can actually then answer the questions coming in from the nurses, and then obviously it will be verified by a live person sitting there. It's a pilot just started off.
Actually, when we looked at data from trials in Bangladesh, trial from India, etc., that improving supervision is actually as impactful as improving training. And there's very little that has been happening in this field. So that's why really we focus on this quality and this supportive supervision. So the solution that we created is a solution that really is very simple. The idea is there's a lot of supervision that's happening in the system that is typically administrative, that is top down, is the people at the top tell the typically female frontline workers, this is what you should do. And what we felt is it would be great at some point that the top could actually listen a little bit more to the bottom and actually understand better what are the real problems and start working on solving those problems. And in addition, really making sure that we're improving the motivation of the frontline workers in the process. We're creating workflows to enforce the fact that there's a joint debrief between the frontline worker and the supervisor. And really what's important is first we spent a lot of time to automate the complimenting, the praising the frontline worker by the supervisor, making sure that the supervisor actually is reinforcing what's going great in a very structured manner. But also facilitating the discussion of what went less well, but not in a, this is what you didn't do well, but in transforming the question to what were the challenges that you faced, why were these things that were not possible to achieve. Basically asking the frontline worker, what are the problems that you're facing and how can I help you solve those solutions?
To talk about the power of the health technologies to accelerate reduction in MNCH mortality.
You know, majority of the interventions in maternal health and child health government is already taken. Now the gains are going to come if since India has become the third largest innovator and innovations are in plenty, and you have to take those innovations and get into the system. So I am going to touch on some of the product innovations and AI actually.
The AI-powered algo can analyze the vast amount of data from electronic health records, medical imaging and other service sources to identify pattern and risk factors associated with the MNCH. Early detection and diagnosis can lead to timely intervention, reducing mortality rates. Also, if you see in antenatal care, we have latest like ultrasounds are also coming, which is latest one, which actually have a probe, and you can have basically on the back end you have this basically the entire and they can tell you that what is whether that ultrasound is fine, baby is fine, and other things. Intrapartum care again, is a highly skilled care. If you provide, you can the maximum mortality happens during that period, and the interventions are already there. Like Janitri is one innovator which has come up. There's a patch which is stuck to the abdomen, and you can monitor. It's similar to cardio tachograph. So. And they have various versions of it now, and you can use in the hospital, also into the smaller health facilities. Similarly, you have for postpartum hemorrhage, you have intrauterine balloon tamponade. Two types of already in the market, which is already there. Same, of course, for postpartum care assessment of both the mother and the baby when they are discharged, and of course various other interventions which can be used. Telemedicine and remote monitoring. AI-driven telemedicine platform can expand access to health services in remote and underserved areas. Pregnant women and newborn mothers can receive essential prenatal and postnatal care through virtual consultations and remote monitoring devices, enhancing the chances of healthier outcomes. Health education and awareness. Powered chatbots and virtual assistant can provide accurate and timely health information and to expecting mothers and caregivers. This helps raise awareness about healthy practices, nutrition and warning signs, empowering individuals to make informed decisions about their health.
Good morning, everyone.
I'm going to talk a little bit about intergenerational linkages, which again have a lot to do with data gaps, and then interventions, which again might have a little bit more to do with data gaps than we might think. So this is a paper which basically highlights the multi-sectoral problem, which you've already heard about. So I'm not going to talk about the different risk factors. But what I'll tell you here is a little bit of a data story. This figure comes from an analysis of districts in India from the NFHS 4. What was special about this is that was the first time that we got a picture of all of the districts in India and the levels of stunting across districts in India. It was the first time we had that kind of data. Before that, there were district representative surveys, which included the district level household surveys. We also had the annual health surveys, but those were all fragmented and none of them collected data on anthropometry. So when we collected the data from the NFHS 4, that was the first time that we could do an analysis across India, which gave us a picture for districts. But now you can see that with the NFHS 5, we keep getting district level data so we can follow the same units over time. So one of the lessons that we learn about data gaps here is that we need to focus on the geographies that we want to capture where actual decision making is done. And I think one of the reasons why we started focusing on districts is because we realized that many of the decisions are made at the subnational level. And so we started to focus on that data and collected it. This was a figure that you would have seen in the previous session. Ms. Deepika Anand gave that because we worked with them on the same paper, so I won't get into this. It's again about multi-sectoral problems. But another data issue that I'd like to bring up here is how do you find out about which policies can cause change in undernutrition or drive undernutrition? You usually don't have those kinds of variables in data sets. So for that, you do a desk review or you find out what were the different kinds of policies that were introduced across different states in India. You try to get clever and you try to match those policies with the data on kids, and then you try to tease out some sort of an effect size from the data. So a lot of studies that you'll see in public health will do those kinds of analyses, but again, it's a big challenge for researchers to find the right kinds of variables, to match them onto the same year that you have data for, to get clever and do a quasi experiment. So there's a whole process that's involved in actually generating evidence, and it's the data that limits the evidence that we can collect. So the big highlights of policy changes here is, yes, we're able to at least connect some dots, but we're not able to causally tell you what's driving what from the policy side to the outcome side, because you have to rely on quasi experiments. And as you might know, randomized control trials at the top of the pyramid, quasi experiments sit just below that. So a lot of times you get pushed back that these aren't very causal. Again, the National Family Health Survey is the one survey that lets us track nationally the set of interventions that are being delivered by the government through its various programs like the ICDS and the NHM. And there's one clear message here, and the message is that we've made some tremendous strides in the past 5 years in increasing coverage across the continuum of care. So as you can see, most of the interventions are showing a positive trend, and so this is a really heartening bit of evidence that you can generate from the NFHS data. And then you can see here another thing that comes out is that across the continuum of care, you have a lot of spread heterogeneity across states. So these bars, they represent the national average. And so you can see most of the cases, the national average might be high, but then those dots that are there around it are showing you the state heterogeneity across India. And so what we know is that there's still a lot of heterogeneity across states, but at the national level, we are seeing high levels of coverage for many of the interventions. To make up for the time. Yeah.
What the AAA platform is and what is the solution I am actually taking on and saying that this is going to solve the problem of integration. So AAA platform is established on the principle of integrated database systems, and it starts with the simple process of what we say and call is mapping. So the AAAs converge and actually map their geographies and list down all the beneficiaries under this coverage. Yes, so as I said, that integration, as intuitive and as easy it might sound, it's a challenging task to undertake. And that's primarily because you would see that each frontline worker records in each individual, same individual with different numbers and sometimes with even different names. So what AAA does and the AAA platform does is unify the records of the AAA by giving it a unique beneficiary number and a unique household number tagged to it. More, when this integration is established in the records of the AAA, what it does is that then they are able to use these records, 2 monthly meetings together, identify, review all the cases that require priority. I'm going to leave out everybody with a teaser of a technology solution that we have. And this is something that we have piloted in Rajasthan. It's called the Integrated AAA app. It provides a integrated user level access to the field level, to the AAAs, with which they can create, update, and maintain the databases of the geography and each individual that they serve. Just imagine that an Anganwadi worker identifies an underweight child, and this information is not lost in the registers, but immediately an update is given, or an update just automatically pops out on the mobiles of the ASHA and the ANM. They're prompted for quick action, and this saves somebody to slip into malnourishment.
Thank you very